In this episode of the ASC Podcast with John Goehle, we discuss the latest news, including the delay in the pre-authorization pilot and Anthem's new policy on out-of-network providers. In our focus segment, we discuss the final 2026 CMS ASC HOPD payment rule.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs, and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 263 of the ASC Podcast with John Goehle, recorded on December 3rd, 2025 from our temporary studios on Hilton Head Island, South Carolina. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by their relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry and is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So I think we should probably start off by pointing out that we are recording using our portable studio here down Hilton Head Island. So we're recording on our kitchen table.
Yes,
back,
and
back to our beginnings.
We're kind of in vacation mode. It's taken me a couple times to get this out.
That's right. That was take 4, I think. But we're enjoying our stay down here. The weather hasn't been great, but we're knocking off a couple episodes during this stay, and as well as having some fun on the ocean here. We have a lot of things going on, Sue. First of all, the multi-state conference a couple weeks ago was a huge success, really the most successful conference we've ever done. I know you're working hard in getting all of these certificates for the attendees out. We are, if you're waiting for one, it's not for lack of trying. Sue is definitely trying to get them all out, but we have an awful lot of work to do on that. And so for those of you that missed the multi-state conference, it will be available for purchase in a couple weeks when we finish editing it. And of course, if you attended or signed up for the multi-state conference before we actually did it, and we're not able to be there in person, you'll still get recordings from that. While we're here, our doggies are in, you might remember, everybody, that we have 2 golden retrievers. One is a 5-year-old Rosie, who is the mascot for our company, and our 6-month-old Daisy, who is our new puppy. They are both at a board and train because they need a little bit of work.
They're very, very good.
They are.
We don't have any major issues, but we know somebody that is a really good dog trainer. Yeah. And we thought, well, if we're got to have somebody take care of them anyways, we might as well get a little schooling in there. So.
I was a little bit concerned, though. I don't know if this is good news or bad news. The trainer texted us and said she is referring to the puppy. She is a very smart puppy. Yeah.
He didn't mention Rosie, but but he did say they're both doing really well, considering they've never really stayed with somebody else. He said they're doing great. And then he's going to come and train us on training the puppies which is
probably
the
more important part of this. So.
So we're excited.
So yeah, very fun time that we have down here. We also have a lot coming up. We are starting in probably about a week and a half, a 4-month series with interviews with the accrediting organizations. Our first one will be with Quad A. We were able to interview Tom Terranova from Quad A, and it was a wonderful interview. So it went on for an hour. He had a lot of great insights, and I think that's going to be a great episode. So that'll kick it off, and we're working on getting interviews with all the other accrediting organizations. So it'll take about 4, maybe even 5 months to get that done. And then we also have 2 interviews coming up with SIS, who's one of our sponsors, regarding one of them is going to be on technological advances in coding and billing, and then we're also going to have a discussion of the challenges in getting physician buy-in and compliance when you're implementing an EMR system. And that's with our friend Darren Smith. It was an interesting interview. All those have been recorded. We just have to put the episode around them, and I thought that both of them were just fascinating conversations. So that's a lot to look forward to. So, Sue, why don't we start with some of the recent news? A couple major things have happened.
Yeah.
So let's start with our conversation about Anthem's new policy on out-of-network providers, which is dominating a lot of ASC administrators' inbox conversations recently. Anthem's new out-of-network policy is set to begin on January 1st, 2026 in 11 states.
Yeah, and it's a big shift, John. For any in-network facility, including ASCs, if an out-of-network anesthesiologist, pathologist, radiologist, or assistant surgeon is involved, Anthem will automatically reduce the facility's allowed amount by 10% on that claim. In cases of repeated use, they reserve the right to terminate the facility's network contract altogether. No cost sharing with the patient is permitted, so the entire penalty falls on the ASC.
And I think what's very difficult about this whole policy is that it's a penalty for the surgery center, and yet they don't have any control over whether that provider is an in-network or out-of-network provider, other than to not allow them to be privileged at that organization. And I think that's what really makes this so painful, especially right now. We're already in the middle of a really deepening anesthesia crisis, and I think the anesthesia side of this is probably the most problematic. We all know the national projections are showing a significant shortage of anesthesiologists going through at least 10 years into the future. Not only anesthesiologists, but CRNAs also. And, recent surveys of ASC leaders have shown that anesthesia coverage is their single biggest operational threat heading into next year, up substantially from prior years. Many centers are already paying 6-figure stipends to their anesthesia providers, providing revenue guarantees or shifting to expensive locum tenens and agency models just to keep the surgery center running. So I think this whole issue with Anthem is bound to make that problem even worse than it already is.
Exactly. And when it's so difficult already to find anesthesiologists, the idea that an ASC can just choose an in-network anesthesia provider isn't realistic right now in most markets. Forcing that choice under a threat of a 10% cut or network termination could lead to delayed or canceled cases and higher subsidy costs to attract in-network groups, or in the worst case scenarios, reduced service lines in those 11 states. And those states are, again, Colorado, Connecticut, Georgia, Indiana, Kentucky, Maine, Missouri, Nevada, New Hampshire, Ohio, and Wisconsin. And like we said, it's really, we just don't need any more issues with anesthesia supply. It's
right. And
really
they're paying
bad timing.
Stipends, and then they're going to take a cut in the pay from Anthem. I don't know how this is. I'm very concerned about this. And the pushback, from the industry has been very swift and very broad. ASCA has formally objected, pointing out that facilities really don't control physician contract. Well, they don't control physician contracting or patient referral patterns in most cases. And so there was a joint letter from the American Society of Anesthesiologists, American College of Emergency Physicians, the American College of Radiology, which called the policy deeply flawed and operationally unworkable. And for example, in Ohio, the Ohio Association of Ambulatory Surgery Centers, good friends of ours, is actively mobilizing members to highlight how this will exacerbate the access issues in the state already struggling with these anesthesia coverage issues.
So I guess the bottom line for our listeners, if you have significant Anthem volume in any of those 11 states, pull up your contracts now, model the financial exposure, and consider joining ASCA's and consider joining ASCA's advocacy efforts. This policy layers a reimbursement threat on top of an existing workforce crisis, and the combination could be devastating for margins and for patient access if it's implemented as it is written.
We will, of course, continue to keep our listeners updated as ASCA and the specialty societies press Anthem for revisions to this policy, but be prepared for it to begin on January 1st, and of course that planning needs to begin now.
Yeah. And I think it's great that ASCA's upcoming conference is going to be paired with one of the anesthesia societies. So, maybe there'll be some problem solving.
Yeah, and I think that it couldn't have come at a better time, Sue. I mean, it's been a long time since the two organizations have come together, and I don't think it was really because of the anesthesia crisis that they were doing this. They've just had a long history of trying to find common ground.
Yeah.
And but the timing couldn't be better. So, and to that end, make sure we always want to call out our friends over at ASCA. Don't forget to become a member. And I believe the sign up has begun for the ASCA 2026 already, which is in Washington D.C., which in itself will be an interesting time, being right in the capital. But we do have some good news, don't we?
Yes, we want to. And so the next thing that we wanted to talk about is a headline that's actually got us all breathing a sigh of relief: the delay in CMS's prior authorization pilot program. For those who might not be familiar with this, let's quickly run through what this is all about and why it matters so much to our centers. So prior authorization has long been a thorn in the side of outpatient care. So this is when payers, including Medicare, require pre-approval for certain services to confirm medical necessity and curb potential overuse or fraud. In the ASC world, this often means extra paperwork, delays in scheduling, and frustrated patients could be waiting weeks for a green light on procedures that are routine and evidence-based in our settings. So CMS first floated expanding prior authorization back in 2020 as part of broader efforts to protect Medicare's bottom line, but it's evolved into targeted pilots. This latest one, announced earlier this year, zeroed in on ASCs for a 5-year demonstration, kind of a trial, starting December 1st, 2025, in 10 high-volume states: Arizona, California, Florida, Georgia, Maryland, New York, Ohio, Pennsylvania, Tennessee, and Texas. This included a list of 41 procedure codes, things like cosmetic leaning or variability-prone services like blepharoplasty for eyelid lifts, Botox injections for migraines, paniculectomies for excess skin removal, rhinoplasty, and a handful of vein ablation treatments.
And I think, Sue, those procedure codes are just not very high volume procedure codes. And I again, it didn't make a lot of sense, and thank goodness ASCA was able to get this delayed. And I believe really it's their pushback that really hit. And the hit to the surgery centers could have been pretty quick and pretty brutal. But again, it's not very high volume. It's just more of an annoyance, I think, than anything else.
Well, it takes up time.
Right. Well, and our concern has always been that, as Medicare implements this, the problems with the computer systems that would have to accommodate these pre-authorizations could very well be delayed, and that is indeed what they were giving feedback to CMS on. And ASCA's analysis showed that 24 of those 41 codes had fewer than 100 claims nationwide in 2023, and 5 aren't even payable in ASCs, making the whole thing feel arbitrary and resource intensive. And in high-density states like Florida or California, where ASCs handle millions of these outpatient cases annually, even a modest uptick in prior authorization could cascade into thousands of delayed procedures, increase administrative costs, and higher no-show rates as patients jump through hoops. And again, it really exacerbates, just like everything else that seems to be stressing surgery centers right now, just exacerbates an ongoing staffing problem that we have while tying up billing teams on red tape when they're already short on anesthesia and nursing. While the goal was program integrity, critics argued it risks access barriers without meaningful fraud reduction, which, of course, echoing past CMS pilots.
And that's where the delay comes in as a big win for us. ASCA lobbied CMS in October, highlighting the government shutdown's ripple effects on Medicare administrative contractors' readiness. Essentially, no one was prepared to handle the influx without chaos. CMS listened. They staggered the rollout. Now, providers in California, Florida, Georgia, Maryland, New York, Pennsylvania, and Tennessee can start submitting on January 5th for services after January 19th. Arizona, Ohio, and Texas will follow on February 2nd for post-February 16th dates. It's not a full reprieve, but it buys precious time to build systems, educate teams, and maybe even refine the list before it goes full scale. Broadly speaking, this delay underscores CMS's rocky history with these initiatives. For one example, the home health pre-claim review demo that got delayed, expanded, sued over, and resurrected multiple times, drawing fire from lawmakers like Senator Mark Rubio for being overly broad and ineffective at curbing improper payments. As one analysis put it, these efforts often promise efficiency, but they deliver inconsistent, confusing, and operationally burdensome results. For ASCs, it's a reminder to stay vigilant, engage with ASCA, monitor your state's timeline, and document every snag to build the case for exemptions or any tweaks that maybe could be helpful.
Yeah, and again, there doesn't seem to be a past history here of these pre-authorizations actually accomplishing the goal that they set out for. And I'm very happy, that ASCA, really stuck to its guns on this. However, I have a feeling that in a future episode we'll still be talking about this as it actually comes into play, because of course this is a delay. It's not it's not the end of it. So probably the biggest news of the last couple of weeks has been, of course, the final 2026 payment rule. So let's take a short break, and when we come back, we're going to delve deeply into the final payment rule for 2026.
If you work in the ambulatory surgery center industry, whether you're an administrator, a nursing leader, a medical director, an owner, or part of the clinical or business office team, there's one resource you should be using to stay sharp, stay compliant, and stay ahead. ASC-Central.com. ASC-Central is the premier online hub for ASC education, leadership development, and ongoing professional support. It brings together decades of ASC expertise, practical tools, and industry-leading training programs, all built specifically for the challenges of the ambulatory surgery environment. One of our most popular offerings is our series of leadership bootcamps, the industry's most respected training programs for ASC administrators, directors of nursing, and business office managers. These bootcamps are not passive lectures. They are mentored, structured, immersive learning experiences that walk you through every aspect of ASC operations and leadership. And many of our bootcamps provide AEU credits for CASC, certified administrators, and IPCH credits for CAIP certified infection control professionals, helping you maintain your credentials while you strengthen your leadership skills. ASC-Central also features a comprehensive collection of on-demand educational programs. These are full-length virtual conferences recorded over the past several years, covering regulatory compliance, quality improvement, credentialing, infection control, finance, governing body education, and much more. These programs are detailed, engaging, and highly practical, and many of them also offer CASC and CAIP continuing education credits. For ongoing access and continued support, ASC-Central offers a range of membership programs. Patron membership, designed for listeners of the ASC Podcast, includes access to regular group Zoom sessions, an extensive resource library, and complimentary access to several key conferences such as the Conditions for Coverage, Medical Director, Credentialing, and Finance and Accounting programs. ASC-Central Premium Access, our most comprehensive membership level, includes everything in the Patron tier, plus full access to all leadership boot camps, private consultations, live and recorded conference access, individualized staff training, and ongoing interaction with leading experts in the ASC industry. So if you're ready to elevate your knowledge, strengthen your team, and gain access to the most complete ASC education platform available, visit asc-central.com or email us at info@ascpodcast.com for more information. ASC Central, where ASC leaders come to learn, grow, and succeed.
So in today's focus segment, we're going to be diving into the final 2026 Medicare Hospital Outpatient Department and Ambulatory Surgical Center payment rule, which was released in November. Every year, this rule sets the foundation for how ASCs get paid, what quality measures we must report, and what operational changes we need to prepare for. And because Medicare influences not just fee-for-service patients, but also Medicare Advantage and even commercial payers, the impact of this rule is much bigger than many people really realize. Sue, this is easily one of the most important regulatory updates our listeners will face each year.
That's true. And so before we get into the specifics of the 2026 rule, I think it's really important that we explain how this whole process works, because not everyone in the ASC world comes from a regulatory or a financial background.
Especially all of our nurses out there, right, Sue? Yes. You and I joke a lot because I make you read some of the stuff here. And for those that are not aware, Sue's background is nursing, and she had absolutely no financial training as part of her training, as many of you out there that are listening. And even if you're not in a leadership role, I think it's important that you understand how the payment rule works. So I'm going to leave it to Sue to explain from a nurse's standpoint, or at least using nursing words. Go ahead, Sue.
So every year, CMS follows a consistent cycle. First, the proposed rule, which is usually released in July. This is CMS's draft plan for the next year. It includes a proposed payment update, changes to APC assignments, additions or removals from the ASC covered procedures list, changes to the quality reporting program, and any major policy updates. Immediately after it comes out, stakeholder groups, including ASCs, specialty societies, and organizations like ASCA, submit comments pointing out potential errors or unintended consequences.
You might remember, too, that we did have an episode earlier in July when the rule first came out where we talked about that proposed rule, and then we always follow up here. There has been a delay because of the government shutdown, but that it was finally released a couple weeks ago.
So the second thing, which John just mentioned, the final rule, which is usually released in early November. CMS reviews all the feedback and issues the final policies and payment rates for the upcoming calendar year. These final decisions take effect January 1st. So today's discussion is about the finalized policies that will govern ASC reimbursement starting January 1st, 2026.
And again, we need to emphasize that even though this rule is specifically about Medicare, it does have a ripple effect throughout the industry, especially with the Medicare Advantage programs, but also many insurance carriers do it too. So how does Medicare actually reimburse ASCs? And I'm not sure everybody knows this. Even people that have been in the industry might have forgotten this. So here's a kind of a simple, practical explanation of it. Everything starts with the CPT-4 code. And before I go further, we need to note that the CPT codes and descriptions are copyright 2025, the American Medical Association, or AMA. All rights are reserved. CPT is a registered trademark of the American Medical Association. Every surgical procedure is billed using a CPT code, such as one that I've known very well, having run surgery centers focused on ophthalmology, 66984, which is for cataract surgery, or 45378, which is a colonoscopy, or 29881, knee arthroscopy. I would say that those three codes there alone probably make up a very significant portion of what is billed out there. And this tells Medicare or Medicare Advantage programs or insurance companies exactly what was done in the surgery center. Medicare then assigns that CPT code to a specific APC. And APC stands for Ambulatory Payment Classification. Each APC groups procedures with similar clinical characteristics, resource needs, and the expected cost to the ambulatory surgery center. Each APC has a national Medicare payment rate. CMS assigns one bundled facility fee per APC. Now, this is important to note. This payment, this bundled facility fee, covers the room time, the nursing staff, the supplies, the equipment, the anesthesia supplies, pre- and post-op care, and certain drugs and items that are packaged. The surgeon is paid separately, as is the anesthesiologist, under their fee schedule. And by the way, so does the pathologist. And then Medicare adjusts those rates, that national payment rate, by a geographic wage index, which can vary very dramatically, by the way. So, for example, in high-cost major metropolitan cities, that rate could be significantly higher than rural areas with salaries that are much lower. So your actual payment is the APC amount multiplied by your local wage adjustment factor. As I mentioned, Medicare Advantage plans do follow the Medicare program usually. They negotiate their own rates, but almost all of them reference Medicare payment structure, and they follow the APC assignments that are reassigned every year. And they pay often they pay a percentage of the Medicare ASC fee schedule. So when CMS changes a rate, Medicare Advantage rates often shift with it. But also, many commercial insurance carriers also tie into Medicare. You'll see in contract language things like 120% of the Medicare ASC rates, or based on Medicare APC groupings. This means CMS's decisions, as we said before, ripple through the entire payer mix. And then also, quality reporting ties into this. If an ASC does not participate in the Medicare Quality Reporting Program, CMS reduces the ASC's entire payment update for the year by 2%. So if there is a 3% increase assigned, the non-compliance setter would only get 1%.
And now that we have that foundation behind us, the changes we're about to discuss are going to make a lot more sense. So now that we know how Medicare pays ASCs, here's what CMS finalized for 2026. The big themes this year include a continued positive payment update aligned with the hospital market basket, removal of the NHSN COVID-19 reporting requirement, reversal of a major proposed payment cut for cataract surgery, and CMS backing away from a proposed new survey requirement on post-op instructions. So glad to hear about that one too. And let's go through the major elements one by one.
So let's start with the ASC payment update for 2026. So the 2026 final rule continues a policy which was extended through 2028 that ties the ASC payment updates to the hospital market basket. Those long-term listeners will know that in the past, up until about 4 years ago, that reimbursement was tied to the consumer price index increase, which is not at all related to healthcare costs. And then after applying the productivity adjustment, ASCs get a modest positive increase for 2026. So this stability in the use of these factors is important. For years, ASCs lagged behind hospitals because CMS used that consumer price index. Tying us to the hospital market basket helps keep our updates aligned with true medical inflation. So CMS finalized at a 2.6% overall increase in the rate, and this is up from the 2.4% that was originally proposed. And this is driven by a projected 3.3% hospital market basket increase netted against that dreaded 0.7% productivity adjustment. Although the overall update is modest, the net impact on providers can vary considerably once budget neutrality adjustments, wage index change, the APC weights are factored in. Remember that the APC weights are adjusted every year based on hospital cost report data, so that 2.6% increase is to the total payment system. Individual rates by CPT-4 code can vary significantly. And then in the final rule, CMS made a major expansion to the ASC covered procedures list, or the CPL. The agency eliminated 5 longstanding regulatory exclusion criteria, which previously prevented many procedures from being considered for ASC payment. By removing those barriers, CMS is placing greater responsibility on the physicians to determine on a case-by-case basis which patients and procedures are appropriate to be in the ASC setting. So as a result of these criteria changes, CMS added 289 procedures to the covered procedure list. And additionally, CMS added 271 codes to the ASC covered procedure list that were removed from the inpatient-only list in 2026. This represents one of the largest single-year expansions in the program's history and reinforces CMS's ongoing objective of shifting medically appropriate care to the lower-cost ASC setting. This expansion also aligns with another major structural change with CMS, the phased elimination of the inpatient or the IPO list. Now, CMS, as we talked about when we talked about the interim proposal, is moving forward with removing the IPO list or the inpatient-only list entirely over a 3-year period, completing that phase out, or at least planning to complete that phase out by January 1st, 2028, a year earlier than was originally proposed. During the transition, these procedures will remain protected from site of service denials, RAC referrals, and RAC reviews related to patient status under the 2 midnight rule. That protection stays in place until HHS determines that a specific service is routinely performed in the outpatient setting. However, CMS did emphasize that contractors may still deny claims when a service is not deemed reasonable or necessary. So I thought this was also interesting. CMS also noted that existing safeguards such as physician judgment, state licensure requirements, accreditation standards, and the hospital conditions of participation, malpractice laws, and CMS quality monitoring programs continue to ensure patient safety as more procedures shift to the outpatient environment. Regarding beneficiary cost sharing, CMS is unfortunately not making any major changes. The rule also clarified, importantly, that removing a procedure from the IPO list does not require it to be performed outpatient. In other words, it can still be done on an inpatient basis. It simply permits payment in either inpatient or outpatient settings based upon clinical judgment. And remember, ASCs that do not meet the ASC quality reporting requirements will incur a 2 percentage point reduction. In combination with significant expansions to the ASC covered procedures list, the payment update may shift significant service volume from hospital outpatient departments to lower cost ASC settings over time. So let's hope that that indeed happens, and let's hope that there aren't major changes next year to what we've been able to accomplish this year.
So one of the biggest changes this year is CMS officially ending the COVID-19 NHSN reporting requirements. So this includes removal of COVID staff vaccination tracking, elimination of COVID surveillance reporting, and removal of the associated COVID vaccine measure from the ASC quality reporting. For many centers, this wipes away one of the last remnants of pandemic-era regulatory burden. Thank goodness.
And I think probably people have stopped the podcast here and are jumping up and down for joy, because I know this has been truly one of the most frustrating things, especially since it's the only item that has to be done on a quarterly basis here. So this will hopefully save your staff quite a bit of time. And then I think one of the most exciting things here, for a couple of standpoints, was the reversal of the cataract surgery payment cut. So now let's talk about this issue. It caused a major panic during the proposed rule. There's a very large decrease in cataract reimbursement. And the specialty organizations came back and said there must be something wrong with this calculation, and actually showed mathematically how incorrect it was. CMS now admits this reduction resulted from a calculation error involving cost packaging and weight assignment. So in the final rule, CMS corrected the error and restored cataract surgery reimbursement to the appropriate level. Given that cataract surgery is one of the most common ASC procedures nationwide, this correction is critically important. So this resulted in a shift from a reduction to an increase in the cataract reimbursement. And Sue, when I was in, I can't remember which state association I was at, but I think it was in New York. I was with Kara Newberry. And I brought something up which I don't know that anybody else thought about, is if they made this calculation error here, doesn't it make you wonder whether there's, and it was caught because it was so major.
So blatant,
It just calls into question how many other times are there errors in these calculations. So
it just really points out how important it is that everybody looks at this, because, even if eventually they found out it was a mistake, I feel like once something's set in stone, it can be just hard to reverse it.
Yeah.
So it's really important to pay attention when these proposals come out.
And it could have been a major impact on those surgery centers, since it is the most common procedure done. So a big win for the industry there.
And another thing we were very relieved about, in the proposed rule, CMS had floated a new survey measure requiring ASCs to capture patient feedback on the clarity of postoperative instructions. But the proposal generated a lot of concern. So what would the survey tool look like? How would response rates work? Would the measure be specialty neutral? And how would tech platforms adapt? And how would it interact with the OAS CAPS program, which restricted an ASC's ability to do other patient surveys? Just so many questions. And surveys are becoming so complicated right now. And in my opinion, a lot less useful.
Yeah, I thought this was a very good measure, but it's one that's already being captured as part of OAS CAPS. Not in the same way that they were going to capture it here. And of course, again, not to beat a dead horse, but when we ended up having to go with OAS CAPS, we lost the ability to create measures like this on the fly in our surgery centers. And then when this came out, which clearly there was no communication between the people that created the OAS CAPS measure and this one. It clearly was going to cause quite a bit of problems. So another major win on the part of ASCA in being able to get this done. So, but unfortunately, CMS ultimately decided the proposal wasn't ready and that this was a removal. So I'm not sure that it's gone forever. We'll see what happens with it, but at least it's not in the final rule. Finally, I do want to talk about quality reporting program reminders. When we're talking about Medicare quality reporting, remember that all existing measures from 2025 remain. There were no new measures added after they removed that one regarding the survey. The COVID measures were removed, which I'm sure is a big relief, and that the 2% penalty still applies for failure to meet Medicare quality reporting requirements. So even if the quality reporting program doesn't directly change APC rates, it absolutely affects your Medicare revenue if you're not compliant. We should note that if you do relatively few Medicare cases, you might be able to opt out of the Medicare quality reporting program. I don't know that everybody knows this. You may wish to read more about this on the ASC Quality Reporting Center website if you are in that situation, and we'll provide a link to in our show notes to that website. And if there's a big demand for it, we might actually include it in a future episode here. So let us know if you'd like to learn more about it. So let's end by just talking about what you as an ASC leader should do now based upon what we've been talking about. First of all, update your financial forecast using the new 2026 payment rates. And if you are a member of ASCA, ASCA provides a wonderful tool on their website, an Excel spreadsheet that can take the final rates and adjust it for your wage adjustment factor for your community. Eliminate NHSN COVID reporting from your compliance workflow once it's allowed, of course. Review your ophthalmology projections if you're doing ophthalmology or cataract procedures, given the corrected cataract rates. Audit your quality reporting compliance to make sure you're avoiding that 2% penalty. If you're not familiar with this requirement, or if it was not brought up, or if you're an owner of a surgery center or a board member, you might want to ask some questions about this, because what I found over time is that sometimes the leadership in an organization doesn't even know that this quality reporting is not being done. So, 2% is still quite a bit of money to lose here, and it's a permanent loss. It just builds on each other year after year. So I'm going to provide links to the final rule in the show notes, including links to the appendices that include the national rates. And as I mentioned, if you're a member of ASCA, they provide a great spreadsheet that you might want to use instead of the links that I'll provide. And with that, we're going to take a short break. And when we come back, we're going to talk about upcoming conferences.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
So I do want to remind people that we're going to be starting about a 4-month project where we're going to be interviewing the various accrediting organizations that serve ASCs. And don't forget, we're going to be doing 2 episodes with our friends over at SIS on various technological issues. The ASCA and SAMBA Conference and Expo is May 13th through the 16th, 2026 in Washington, D.C. And we will have a booth there. And, of course, I'm always a speaker. I think I'm talking on strategic planning this time.
And the AAACN, or American Academy of Ambulatory Care Nursing's annual conference is April 14th through the 17th, 2026 at the Hilton Orlando in Lake Buena Vista, Florida.
And you might want to watch the ASC-Central.com website as we announce the various conferences in 2026. They're almost finalized, and perhaps by the next episode we'll be able to finally announce it. But in January, we will be restarting our ASC Director of Nursing Bootcamp. And then later on in the first half of the year, we'll have the ASC Administrators Bootcamp. We're also going to be doing a 1-day Quality Improvement Conference and a 1-day Human Resources Conference. And that's tentatively scheduled in March right now. But again, those dates they haven't been finalized, but they will be out. But they will be announced on the website as soon as they're finalized. And again, visit ASC-Central.com for more information. On-demand versions of the ASC Director of Nursing, ASC Administrators, and the ASC Business Office Managers Bootcamps are available on the ASC-Central.com website. And don't miss out on the benefits of joining our Patron Member Program, which includes right now over 500 members. And it's available at ASC-Central.com. This comprehensive membership platform is your go-to resource for all aspects of ASC regulatory and accreditation accreditation, compliance, operations, and financial management. It's designed with the busy schedules of administrators, nurse managers, and business office managers in mind. By becoming a member, you gain access to regular Zoom sessions, typically held weekly, where you can engage with other patrons and our podcast team, but that's just the beginning. Your membership unlocks a wide range of resources, including access to virtual conferences, such as our credentialing conference and our conditions for coverage conference. And you're also going to find valuable tools like sample policies, procedures, forms, and our highly regarded fire and disaster drill kits. Your support of the Patron Program helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. To learn more and to become a member, visit ASC-Central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community, and be sure to subscribe so you never miss an episode. We appreciate your feedback and suggestions for future topics. Reach out anytime at comments@ascpodcast.com. A special thank you goes out to our incredible team, sound editor Susan Cronkite, executive producer John Goehle, and our committed research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Kelleritis, Jim Masters, Stuart Rosenberg, Amy Cronkite, Lori Rodericks, Kathy Fode, Donna Macchio, Christina Norman, and Katie Pearson. Your hard work makes this podcast possible.
Our theme music is by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll see you in our next episode.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.